I have collaborated with Philips Research North America for the sake of this talk, but we didn't get any funds from them. So the message that we want to pass is that the medical informatics are not better than clinicians. As a matter of fact, it seems that when clinicians use scientific methodologies along with medical informatics, it's better than clinicians alone. So I would review past, present, and future of electronic medical records and its role in acute kidney injury. All of us remember all these paper charts that was very difficult to review patients for the research or clinical applications. Electronic records have been through several different generations, and they grow from generation to generation. We are at least at the stage, third generation of electronic records at the moment. So first generation were called the collectors. They were able to collect clinical data like blood pressure or heart rate or respiratory rate. Second generation were documenters, were a group of medical records that they had printer with them. So they could print out all these generated databases and add it to the patient's medical record. Third generation, that is the generation that we are currently using in most of the hospitals across the developed world, are called the helpers. They help decision-making support across ambulatory and in-hospital patients. Fourth generations or partners have significantly higher level of sophistication by providing significant decision support capabilities. They are operational across the health care continuum, which means that they start from outpatient to inpatient, and they also provide documents that are medico-legally valid. Fifth generation, that is the generation that we are currently working on, includes significantly complex algorithms and integrated systems to be able to provide significant help in decision-making processes, not only for clinicians, but for patients as well. These electronic records do not stop in medical centers. It goes with patients to their home, and you can follow these patients at home as well. So we came a long way. In 1953, the first cerebral artery pressure monitor was devised in ICU. Following that, EKG machines and first hospital information system was placed in 1960s. 1961, first computer in ICU. That's the time that first person in space was presented. Also, first ICU monitor was in Japan in 1967, the year I was born. These monitors basically were as big as the patient bed. So Whalen-Shubin reported in 1966 the first electronic record system in the critically ill patients. They generated all these data sheets that include significant number of information, very hard to interpret. As a matter of fact, when you look into the machines that they use to generate all this data, you see a tower of machine to be able to generate some data, printout data that includes information that is not very actionable. Indeed, the machines were so big, they needed to have a computer room with several technicians to be able to mine this data to be able to use it in clinical arena. Now, we came a long way. 1973 to 1979, first generation is over. They added printers and then up to 1992. And as far as 1992 up to now, we are using third generation of medical records. Third generation is very sophisticated. It is portable systems. It has graphic interface and network abilities. However, it is very fragmented. So all the information comes from radiology, laboratory, or other sources of information. They are in different fragments. They are not linked together, so it makes it difficult to provide any action or decision support. So what are we doing at present time? It seems in the last 10 or 15 years, the use of electronic records by physicians has significantly increased. From somewhere around 20%, 1 in 5, has increased to half of the physicians. However, most of these physicians or hospitals use very basic systems of data collection. Fully integrated medical systems are pretty rare. So in 2010, only 10% of facilities were using fully functional system. We indeed joined that group in 2009. So what is important for ICU teams is that after all this data are generated by different sources, we need to package them into information that talks about organ status, relevant history, relevant therapeutics, and relevant information. And that helps us to generate data to make a decision regarding the diagnosis or treatment of these patients. Now, we have all this data. How can we use it? You remember these sheets. There are a lot of spaces there is nothing in it. There's no man land in that, and it's very difficult to interpret all this data. In comparison, you have seen these sheets as well. This is not interpretable either. So we have huge lack of data or data deluge or data flood. As a matter of fact, when you look into how many databases exist for each patient in ICU, it's absolutely mind-boggling. So you look into administrative systems, including patient identification, scheduling, barcoding, and so forth, to other clinical systems, including emergency department, outpatient visits, or blood bank, and also databases exist for each patient within ICU system, from pathology, from laboratory, from radiology, clinical notes, nursing flow sheets, and so forth. We looked into data generated for each patient in ICU day. The orange part is the first day of ICU. If we exclude all the vitals in this figure, you see that even without vital signs, there's significant load of new information coming out in the first day of ICU and continues for a few days after ICU admission. So we have this issue of data flood because we have more sophisticated tests, we have increased archival capacities, also we have increased sophistication of data delivery system, which makes it, again, difficult to interpret all this data. The other issue is that although using electronic medical records in several different settings has shown to improve patient outcome, for example, in this study, decreases medical errors, decreases poor mechanical ventilation strategy, and decreases pressure ulcers. There are some other studies show that implementation of bad electronic medical record can increase mortality. This is a pediatric ICU patient population. By implementation of order entry system, they actually noted significant increase in mortality. So what we did in our institution, we felt that this is enough. IT folks and accountants make our databases that is very difficult to interpret. So we said physicians need to design this, and IT folks and computer medical informatics folks, they have to help us to develop that. So we started with very simple model. So this is a map of our ICU. You can hover your cursor on any of these boxes that patient is in it, and it blows up the box. As you can see, there are different organ systems with different color codes. So the red is bad, yellow is alert, and white is good. So this patient, for example, has everything okay with the kidney labs or urine output, but is on mechanical ventilator. So in the morning when I go to the ICU, start seeing my patients, I can identify patients who are on pressor or renal replacement therapy or mechanical ventilator, try to prioritize who I want to see first. And then if you need more information about each of these patients, we click on each box. It opens information that we really as clinicians need to be able to process the data for each patient based on organ system. So for example, for kidney, I know that this patient made only 12 cc's of urine in the last 24 hours, and serum creatinine, although hasn't shown increase at the moment. Also, this system helps us to manage patients better. So this is the system that we use to comply with surviving sepsis campaign. So diagnosis of sepsis are made in this hour an ED. We needed to measure lactates, send blood cultures, start antibiotics, and give these patients about 30 cc per kg of volume. As you can see, this system can show us lactate is measured, antibiotics is started, culture is sent in here, and also volume 5 liters by the end of these 3 hours is done. So whoever took care of this patient had a PATS score, and this goes into feedback at the end of each week to each provider in ICU. Now, role-based syndrome detection or acute kidney injury sniffers become very common topic of discussion recently. Before we move into AKI sniffer, we need to be able to distinguish between classification or prediction. I will focus on prediction later in the talk, but classification is to predict categorical variables. For example, if a patient has acute kidney injury or doesn't have acute kidney injury. Also classifies data based on a training set and uses it in classifying new data, so it can apply to the new patient population. In comparison, prediction models continuous value functions and predicts unknown or missing values. And I discuss about prediction a little down in a few minutes. So in our ICU, we have many databases. It's third generation medical records. All this data enters a single center server. And that server links all this data in a near real time, 15 minutes delay to the time that it's generated. We call this center server as ICU data mart. It's queryable and we can ask this database to help us. So ICU data mart is connected to a decision support server, and based on algorithms that we make, we can generate alerts. That alerts go to the hospital router, can go to a pager or a hospital pager or send an email, and that can be used for education, quality improvement process, and hospital management. So we use very simple algorithms to diagnose acute kidney injury in timely fashion. This algorithm rules out all the patients who are already on dialysis, and it uses KDIGO stage 1 criteria to detect acute kidney injury. We know that whoever has a stage 2 and 3 already had acute kidney injury stage 1 at some point. So it doesn't basically decrease the possibility of detecting patients with acute kidney injury. And that generates alert. Now, we did use a test cohort of 482 patients, and we identified patients with acute kidney injury with very rigorous methodology, and then used this sniffer several times, changed the algorithm to come up with the best sensitivity and specificity. And we tested it in another 460 patients to try to validate that. And what we noticed that sensitivity of this sniffer was about 88%, specificity 96%. When we looked into ICD-9 codes, means that the documented notes of the clinicians that indicate acute kidney injury, the striking part was sensitivity. So only 20% of patients in test cohorts had documentation of acute kidney injury while they had acute kidney injury. And that means 80% of patients with acute kidney injury didn't even have any documentation of acute kidney injury in their medical records. In addition, apart from 10 or 15% of patients who clinicians knew they had acute kidney injury before they arrived in ICU, 85% of patients, AKI sniffer detected AKI well before any documentation of acute kidney injury or any intervention by clinicians in ICU. So this is the monitor setting, the console. It's a beta version of the console. So each folder is one patient, and numbers indicate a stage of acute kidney injury. So 0 is no acute kidney injury, 1 stage 1, and there is a stage 3. So if I click on patients who has a stage 3, it tells me what timeline they develop acute kidney injury and what stage. Tells me what criterion they develop acute kidney injury based on. Also tells me the baseline serum creatinine is measured or calculated, and also urine output based on kg per hour. So apart from clinical application of this, we were able to kind of start some epidemiology studies. So this is a cohort of about 8,000 patients on an unpublished data. That sniffer gave us an output of acute kidney injury, hospital-acquired acute kidney injury within few minutes from 2005 to 2012. As you can see, it was striking to see that acute kidney injury incidence, particularly acute kidney injury stage 1 and 2, have significantly decreased over the last 7 to 8 years. And we currently are trying to figure out what has happened to kind of made us do it. We have no idea of why acute kidney injury incidence in our institution going down. But this was used by simple use of a click of a button by sniffer. Now, this is a very sophisticated study, a proof of concept by Wilson, recently published in Lancet. They randomized patients in two groups of about 1,100, 1,200 each. About 1,200 patients received usual care. The other ones received alerts. These patients are a mixture of hospital, floor, and ICU patients and surgical and medical patients together. So what investigators found was that in a 7-day, 14-day, 30-day, and hospital duration, there was no difference between increasing serum creatinine, dialysis, or death. So this study was thought to be negative. As a matter of fact, in surgical ward, it seems that patients who received alerts, they had higher incidence of nephrology consults and even dialysis. The criticism of this study is that resolution of these sniffers are generally very poor when floor patients are included for several reasons. First of all, the frequency of creatinine measurement is not very significant. In addition, urine output data is very poor. They didn't use urine outputs, which is thought to be one of the beneficial points of sniffers because it can detect acute kidney injury earlier. And there was also no documentation of sniffer reliability and precision as well. Now, what is going to happen in the future? We really need the GPS for our clinical decision support. We need something that integrates data and knowledge together, visualize it very well, and also rule-based system provides alerts that allows us to perform well. As a matter of fact, if you drive with 20 miles an hour in a 25 miles an hour area, you should not receive any alert. If you drive 30 miles an hour in 25 mile an hour area, then you should receive alert. If a physician is doing the right thing in the management of fluid, in nephrotoxins, and patient is high risk, they should not receive any alert. So the future electronic records should be able to identify these characteristics. So I alluded to prediction a little bit earlier, but prediction are two different types. So static prediction is what we use currently as prediction models for cardiothoracic surgery or contrast-induced nephropathy. So these are models that are built once at some point in time to be used for forecasting forever in the future. Dynamic models, however, parameters of the model are frequently adjusted. So the new data, when it comes, are collected and they can change the output of the model. They are therefore more accurate, particularly on phenomena that are changeable during ICU admission, which acute kidney injury is included. So for example, a static model using clinical knowledge and clinical data, we can come up with algorithms based on both, aggregate all the algorithms and come up with syndrome status of AKI prediction. So this model is like Apache model. You calculate Apache at the beginning of ICU admission, you predict mortality or hospital length of stay, ICU length of stay using Apache score. These give you a score of 0 to 100 as far as probability of AKI during admission. However, dynamic model is different. It's a lot more sophisticated. So one piece of dynamic model would be potentially using several different clinical data and knowledge to measure tubular flow. Basically, if you have central venous information, pressure information, you have capillary pressure information, you have interstitial space and lymphatic drainage information, then you know how much the permeability of endothelial epithelial cell changes during acute kidney injury. You can measure acute tubular flow minute by minute. And this is just a prediction. So after development of these algorithms, you need to validate it in clinical setting. Many of these models together as variables of a large mega model can provide you a dynamic AKI model. This model allows you change the prediction of acute kidney injury with each intervention you do, and also because it knows what interventions can decrease the change, it can provide you clinical decision support and tell you what to do to decrease the risk of acute kidney injury. What future generation of EMR does. So this is a wish list. I'm hoping that within the next few years we can have such EMR available to us. So first of all, it needs to have ability to detect the clinical context. So certainly acute kidney injury management in a cardiac surgery domain is different from acute kidney injury in septic patients. So it needs to recognize that and try to provide context-specific recommendations. Reduces information overload, so it needs to display task-specific data at the point of care. It needs to provide true decision support, provide real-time feedback with reference to the best practices. It needs to be integrated into environments, so optimize patient-centered outcomes. You need to help us to come up with sophisticated models for comparative effectiveness research, or in silico, or in other words, the simulated clinical trials before we enroll patients in these trials. It needs to provide cost-effective administrative decision-making support to be used in QI initiatives. And also it needs to identify critically ill patients that are outside of ICU so we can provide timely intervention, also enroll them in clinical trials. So take-home points: electronic medical records-driven processes allow earlier and more efficient detection of AKI. I think that all of us agree on that. The clinical effectiveness of such models are not proven yet and remains controversial. EMR has an excellent potential to risk stratify patients for acute kidney injury development by static models, and EMR potentially can forecast acute kidney injury, provide decision-making information to clinicians, and potentially improve AKI outcomes. I'm hoping that within the next few years we can reach that point. With that, I thank you for your attention.